Hey everybody, this is David. My next guest is Emery Neal Brown, and he's a professor at Harvard and MIT. He's also I think, head anesthesiologist at Mass General Hospital. He also does a lot of work at MIT and Harvard, and he just received an award, which was for the neuroscience of anesthesiology. He just got it a couple weeks ago, which is how I found his name. So we're going to have a cool conversation basically about how he turns off consciousness. They don't fully understand all the technology or, all the working components, but they're trying to get more and more accurate, him and his research group, on how to more accurately turn off consciousness and then turn it back on. So really cool conversation. Hope you like it. Let me know what you think.
Would you like to live forever? We are finally starting to understand the human brain. Born from artificial intelligence, singularity, I give you the last machine.
The David Bramante Show.
Hey, Emery.
David?
Hey, thanks for joining me.
Oh, no, my pleasure. Thanks for having me.
Yeah, definitely. So I saw, it was a couple weeks ago, late October, so not too long ago actually, that you received an award called the Schwartz Prize. Swartz Prize.
Right, exactly. Yeah. Mm-hmm.
Yeah, for 30,000. And then from the Society of Neuroscience.
Yeah,
Society of Neuroscience. Cool. And then I would love to know what that is, and then how that works, like how you were given that, like what work was it that contributed to you getting that award, and then what you would normally do with the prize money. Do you do some kind of research project with it?
Yeah, so the Schwartz Prize is given annually by the Society for Neuroscience for someone who's made contributions in theoretical neuroscience or computational neuroscience. And it can be over a career, or it could be something very, very, very specific. And and I feel obviously very fortunate and very humbled to win it, very grateful. The award in my case acknowledges the work that we've been doing, both on trying to understand the neuroscience of anesthesia, both from a theoretical and experimental standpoint, as well as the research that I've done on developing methods to analyze neuroscience data and making it easier to gain insights by having better analysis methods for statistical and signal processing methods for analyzing neuroscience data. And what you do with it, what I've typically done with awards like that is just fold them into my research program. Just
Okay.
view it like a small grant and then fold it into my research program. So I'm obviously every amount helps. I'm extremely grateful for receiving it, both for the acknowledgement as well as for the financial remuneration.
Nice. Okay, and then so for the research program that you have, do you have a team of researchers working on a specific project, specific problem?
Yeah, so I have people that I supervise, so graduate students, postdocs, undergraduates even, that are working on the problem of anesthesia, understanding it from a number of different aspects. And these are done with the people who are under my direct supervision, as well as collaborators. So I have collaborators who are anesthesiologists, engineers, neuroscientists, neurologists, mathematicians, and we have a consortium of us that are working on this problem, because the problem is complex, it's interdisciplinary, and you need a broad range of expertise to do that. So just to give you some idea of how it's set up, we have our human studies that we do either in volunteers or in patients, where we're recording data while patients are receiving anesthesia, try to understand how the effects that the drugs have on the brain. And then there are other studies that we're doing in non-human primates, research, for example, that we're doing with Earl Miller over at MIT and his group, and it's led by Yumi Ishizawa, who's an anesthesiologist at Mass General Hospital, is also an experimentalist doing non-human primate studies. Then we're doing a series of rodent studies as well with Krista Van Dort and Ken Salt at Mass General Hospital, and then with Nancy Coppell at Boston University. She's an expert in dynamical systems and modeling oscillatory processes. And so we're working with her to try to understand the structure of the oscillations. And the human studies are headed up primarily by Patrick Purdon, who's my longstanding colleague. He's a bioengineer and neuroscientist at National Hospital. So it's an interdisciplinary team, you know.
Okay, all right. But it's not a team that reports to you. You guys meet regularly, or it's everybody's kind of working?
We have regular meetings. We have a monthly, and we have a monthly meeting, and one of the monthly meetings, one of the groups presents. So like at our next meeting, the mathematical modeling team is going to present. And it's an integrated discussion of what insights they've gained and what things they'd like to know about the experiments and vice versa. So it's an exchange that involves all the four major groups.
Got it. Okay. And it is I was watching one of your interviews, and is it the main thing that you're trying to accomplish is to figure out what the black box is of what is actually happening in the mind what happens to consciousness
under anesthesia? Yeah, it is. In other words, so let's just be very, very practical. People need anesthesia for surgery.
Right.
And for years, it's been said that it's not clear how anesthesia works. It seems like a black box, as you suggested. And the one thing that we've tried to do is say, well, we know it has to be, so let's just try to localize this. Okay, it has to be acting in the brain. All right, it has to be acting in the brain and central nervous system. Okay, and so first, what do we know? So just that obvious statement is true, and it's important. Now, why do I say that? Because the conventions that are used to tell you how to dose the drugs refer to levels of drug in the blood or levels of drug in the lungs.
Okay.
All right, so the question is, how do those two things relate? In other words, conceptually, the things have to be acting in the brain, but then, there has to be a link to what's happening. These things that we say about blood levels or drug levels, and very often they're conventions. Okay, they're not. So that's the first thing. Then the second thing is that.
So I can clarify. So the feedback that you get as when you're doing your work, that you're using the lungs or the blood.
Right. Forget about put aside what I'm doing. So to be very concrete, if you're an anesthesiologist and you're administering the drug sevoflurane, right?
Okay.
Then you'll know that if you're giving it a certain flow rate, then you're told that at that particular flow rate, how likely it is the person to be unresponsive. Mm-hmm. Okay. So you can see what the flow rate is going into the lungs, what the person is breathing in. And so then you, from that, infer that the person is unconscious or not unconscious based on what that number is. Okay. And so our feeling was we can make that more precise, because if we know something about, we know where the drugs work in the brain because we know what receptors they bind to. And we know the anatomy that connects the various brain regions. So those are things, those are old. Those are things which we've known for years. So then now add one more element to it. Okay. Put the EEG on a patient. And now as you give the drugs, you see these very systematic, highly structured changes in the EEG. Does that tell you something more about how the drugs are working and how you could dose them than just using a convention based on, what the concentration is you're administering is going into the lungs? And the answer is certainly yes. And the reason you can do that is that the drugs systematically create oscillations which are highly structured and inflexible. And so roughly speaking, you move from these high frequency, low amplitude oscillations to highly structured, large amplitude, low frequency oscillations.
Okay.
And in so doing, these oscillations persist as long as you keep the drug going. And they basically disrupt how the parts of the brain can communicate. And you can actually see those patterns of oscillations on the EEG in real time in the operating room.
So you can see the pattern of the interruption.
You can see the pattern which is associated with the interruption.
Oh, right.
The interruption we come to understand by doing animal experiments.
Okay.
But then you see the same pattern when you're in the operating room. So then you can make the inference based on the animal studies or even in terms of some human studies where patients have had electrodes, that this particular pattern is associated with parts of the brain being interrupted.
Okay, got it. Right.
So that's how we've tried to make it, much tighter, if you would, or have a much clearer statement of what's going on. So then the statement would be as I said just a second ago, the oscillations act to disrupt the ability of the various parts of the brain to communicate, because as the oscillations occur, they modify when the neurons, the fundamental communication elements of the brain and central nervous system, they modify when they can spike or when they can transmit little bits of information. And so if they're totally shut down for a while, then they allow them to come back up. They're shut down for a while. That sort of dynamic is going to prevent you from being conscious.
Got it. Yeah, it's interesting. And I was reading that you're also working on something called burst suppression. Is that to pull them out of that state, kind of like on a dime? So you have accuracy, you're trying to get more accurate putting them in, or it's pretty accurate when you put them into that state, but you're refining how quickly you can take them out of the state with burst suppression?
Wait, so there are two steps to it. So first of all, let's just monitor it and know what state they're in.
Right.
Okay. And then as you monitor it and know what state they're in, then you can adjust the drug doses in a more principled way.
Right.
All right. Now, then if you ask, what are the various states? One of the states happens to be burst suppression. And it's just the opposite. Burst suppression is a very deep state.
Got it.
And in general, it's deeper than you need to be just for sort of regular surgery, regular anesthesia for just regular surgery.
So you're not trying to take it to that state, because that's associated with comas and stuff.
Well, in other words, even the states above that in anesthesia they're coma-like states. But let's just say you don't need to be that profoundly unconscious in most situations to have surgery.
Right. Okay. That makes sense.
Let me say it that way.
Yeah.
Okay. So then when you're monitoring, you see that, so you can turn your drug back, you can decrease it. And the people in whom you can have this, who would probably benefit most from this because they go into burst suppression so easily, are older patients. And older can just be patients over 50, let's say, for example.
Okay.
So burst suppression turns out to be a state of profound brain inactivation, which is seen also during states of coma when patients are profoundly hypothermic, or in like some of this disease called early infantile encephalopathy, or Otara syndrome. And what we realize now is that you don't need to be that deep to be sufficiently unconscious to have surgery. So
can you
turn the drug back?
And with these drugs, you can obviously push them lower than that.
Exactly, you can. Mm-hmm.
And with these drugs, can you overdose the patient and kill them with these drugs, or kill the mind with these drugs?
Well, so that's interesting. So let's just say kill the mind. That's a very strong statement. So
yeah, sure.
Let's say you can impair someone's cognitive state. So just to state what we typically see, older patients that have had anesthesia for, let's say, 4 to 6 hours, waking up and having some form of brain dysfunction, either delirium or confusion, not being able to find words, this type of thing, that does happen. And that's something we're trying to reduce the prevalence of that, and reduce the likelihood of it occurring.
And that's a temporary thing, though.
Yes, but it can last for several weeks or so, and so that can be quite annoying.
Okay. And then the other thing was, I saw there's some studies where you guys or your group is using Ritalin to pull them out of that state, like with just make it as accurate as you can.
Right, exactly. And I think that, so this is conceptually something that, is not part of standard practice in anesthesiology at the moment. We usually just let the drugs wear off and, it'll wear off and he'll wake up, sort of thing. But, we started thinking a few years ago, why not just turn the brain back on? Why not give them something that can activate the circuits? Yeah. Mm-hmm. So we're studying that in detail, and I think it holds a lot of promise because, and I think the patients that may benefit the most are some of these older patients who are involved, for this reason.
That have those conditions that can last a little while after.
Right, exactly. And what happens is, so as we get older, think of the nervous system, you're communicating through, think of the connections among the neurons as like wires, like the electrical wiring in a house.
Right.
And if you're someone who's, 70 years of age or 80 years of age, basically the wiring in the house has been around for 70 or 80 years. And it's going to be frayed. So the fidelity with which it can transmit electrical impulses is probably going to be declining with time.
Mm.
So as a consequence, when you give these very potent drugs, which make the circuits in the brain oscillate with these futile cycles, you can just then imagine that the people who are going to pay the highest price for that are going to be the older patients.
Mm-hmm.
So they're the ones who would probably most benefit from something that helps to reverse that state as cleanly as possible.
Interesting. Okay, cool. Well, because I've been talking to some, it's been a wide range of guests recently, but it's all been around consciousness. So I have to ask, because I think you're the most hands-on in this field that I've talked to. When you are administering these drugs, you are 100% trying to, the goal is to stop them from being conscious. So you're disrupting whatever that is in the mind. You know where it is. You see what the pattern, you see what the effect in the patterns are when you do it. But do you have an opinion of where that consciousness lies within the mind?
Okay, so that's a very fantastic question. So let me tell you what my objective is and where it intersects with this issue of consciousness.
Okay.
So my objective is to generate general anesthesia. Okay, so general anesthesia has four main components. So I need to first make sure you're not going to perceive any pain. That's probably most important, because there's certain operations we can do with you wide awake. Like if you have like a spinal or you have an epidural, you could have like surgery on your leg, surgery on your knee, and be wide awake. So the most important thing is controlling pain, all right, or nociception. Then unconsciousness, obviously, if you're having a surgery where they're operating on your abdomen or your chest or like that, you can't be awake and breathe properly if someone's, you're undergoing cardiac surgery or abdominal surgery. So then unconsciousness. Amnesia, meaning you won't form any memories during that time, but if you're truly unconscious, that won't happen. And then the other part is not moving around so that it's easy for the surgeons to operate, all right? And then doing that with you being physiologically stable, heart rate, blood pressure, body temperature, oxygen saturation, all the physiologic variables are well maintained. So that's my objective. That's what I'm after. So you can see unconsciousness is part of that, but it's one of, and also the key thing, the other part of it is having that be reversible. I put you in that state and I wake you up. So unconsciousness is one line item in that, sort of in that list. And so I want to know that you're unconscious. And do I actually know where it is? No, I don't. So let me tell you how I think about it. I mean, I'm the first to say that. So I know that we realize that to generate consciousness requires integration of many parts of the brain. So the arousal systems in the brainstem, the lower part of the brain, the processing mechanisms in the cortex, and the major relay mechanisms or circuits in the thalamus. And then what I've come to appreciate is, so what I need to know, and again, think of me now as a technician, as opposed to someone who really understands consciousness per se. I'm like a consciousness technician. I can tell you when it's turned off. Right? I can tell you, yes, I see these oscillations. I know what parts of the brain they're being generated by. I see the effect that's occurring. So I feel very comfortable that they're properly turned off. And then the more complex question that you're asking is, how do these things integrate to generate consciousness? That's not, in other words, if we do our work properly and inform our colleagues on how these are turned off, they can use our insights to help formulate a clear idea of how consciousness is being produced. And
there are people in your group that are working on that question?
No, we're not working on that. I mean, so I think of the real luminaries in this field, people like, Christoph Koch, or, somebody like George Mashur, who's at University of Michigan, Koch, who's up in the Allen Institute. They're actually working on, consciousness. What makes us conscious? Or like Giulio Tononi, for example.
Okay.
Your
team is on a technical level. Hey, we're going to turn it off. We're going to turn it on. We want to be able to turn it off better, or it seems like that's pretty much perfected, but you want to be able to control it turning back on and just kind of rebooting quickly without any issues that are there, especially for older patient?
And I wouldn't say that we turn it off well at all. In other words,
Oh,
because we should ask the question, can we turn it off better? Because if we turn it off better, that alone may be enough to get rid of some of these side effects.
oh, and
Right.
when you say turn it off better, what is it that what would you like to improve in that process when it's happening?
Well, so for example, you give the drug now, it goes everywhere.
Oh, okay.
Suppose you could make it so it only needed to go to a certain subset of sites, whatever that means, right? Then, because a side effect is indeed that. It's an effect because the drug is acting somewhere you don't want it to act,
Oh, yeah.
right?
Yeah.
And so if you can cut down, once you've injected into the blood, that's it. It's going to go where it's going to go.
And that's
And then,
currently how it works.
yeah, or we have gases, which are still ethers that you breathe in, and the same thing occurs. They go everywhere.
Okay.
And so what you want to do is have a way of controlling where they go so that you can, so if you can control where they go, then when you're done, you can stop that effect. And then, like you're suggesting, maybe now give something that actually helps wake you up.
Okay, cool. And then I had a question just going back. So you guys are doing human studies. The human studies are on waking the consciousness back up. Is that what the study is on?
Yeah, so that's one which we're doing a new round of that. We've completed a segment of them, so we're looking to extend those further. But the human studies are also still on anesthesia, just recording more data and getting more precise understanding of what's happening to patients under anesthesia.
Oh, okay.
Because there's still a lot to be learned there. So, for example, if there are 4 major classes of drugs, let's say the drugs which like the drugs which make you unconscious, which we call hypnotics, the opioids for treating pain, maybe sedatives like dexmedetomidine, or a drug like ketamine. So we've studied propofol the most, but we haven't done as much detailed study in some of the other drugs. So we're trying to complete the matrix of other drugs that we're studying, so we can have a better characterization of how they are turning the brain off and what happens when you stop them and the brain comes back on.
Okay. And then what about the non-human experiments?
So the non-human primate experiments and the rodent experiments are, particularly the non-human primate experiments are really important because you have a brain which is much closer to the human brain. The animals can execute behavioral tasks very much like the humans can. And we have the advantage of now we can put electrodes across the entire brain, directly into the brain tissue.
Oh, wow.
So we can see directly, what it looks like when the brain is turned off, how it comes back. And so that's why the non-human primate experiments are giving us a lot of insight, a lot of important
Where are
insights.
those experiments done?
So those are being done at MIT with my colleague Earl Miller.
Oh, and how many primates are in this experiment?
Well, it varies depending upon what we're doing. So.
Yeah, sounds so crazy.
But standard practice for like non-human primate experiments is for a particular protocol is probably 2 animals.
Oh, okay. All right, interesting. All right, yeah, that was kind of the main thing. So a follow-up would be, so why is it being unconscious and then having the amnesia, those are 2 separate line items? Why are those separate? Because that I don't understand.
Well, it's just important to say. In other words, because, see, those are just behavioral descriptions.
Okay, got it. It's like you got to check these boxes.
Yeah, exactly. Just remember to check that box. Yeah. Mm-hmm.
Oh, okay.
And most of the time, one will be a subcase of the other. Right. But by the same token, there are times when we sedate patients, they don't need to be profoundly unconscious. They just need sedation, like when they're having a colonoscopy, right? And you'll get amnesia for that, even though they were apparently awake, during the procedure, right? So, but when I'm thinking about full general anesthesia, that's just something which we just want to be sure we state.
Right. And then with the check mark of pain, obviously that's the biggest, scariest thing for anybody.
Totally.
And there was a time where major surgeries were happening and they had to just bear through it.
Right, exactly. Before the discovery of ether as an anesthetic, surgery was basically trauma and butchery, and surgeons were actually measured by how fast they could work. Literally, they could do a procedure, most of which were amputations, in a minute or 2 minutes or something like that. I mean, it's horrific to think about that now.
Yeah, it's crazy. It's very crazy. And then with that, is there there's a level of pain where the mind will make itself unconscious, or through some of these operations, people were just, because it seems like from what I've read, people would die from the level of pain, or that never happened?
Oh yeah, well, no,
operation.
I think that's very likely because pain is an amazing stress. And you can just imagine someone having a heart attack because of it.
Right, yeah.
I mean, just simply
like
that.
Unfathomable to have to watch your body.
Exactly, yeah. Excruciating pain. And so the discovery of ether and its use as an anesthetic was a major advance for medicine. I mean, it literally overnight transformed surgery from being, like I said before, trauma and butchery to humane therapy.
Right.
And the surgical advances occur because anesthesiology has become better at controlling the physiology of the body, so that more different and sort of more varied types of surgery can be undertaken.
Interesting. Okay, cool. Thanks for answering all that.
Mm-hmm.
I did have one final question.
Sure.
It's a curveball.
Okay.
You ready?
All right.
Which you prefer, Star Wars or Star Trek, and why?
I grew up in the Star Trek era, so the original Star Trek. So
the 60s.
I saw the first episode when it came on in 1966. I saw the last one. It went off in 1969.
Right. I've watched all those. Those are cool.
And Mr. Spock was my hero. And actually, one of the best episodes, my favorite episode, is the one called The Ultimate Computer.
Oh, which one's that?
It's with Dr. William Daystrom. He invented the duotronic system that controls the starships. And then
cool.
They staged war games where his new control system, which was going to reduce the number of humans needed to control the ship, would be reduced dramatically to, like, the crew. I think the starship had about between 400 to 500 crew members. It would reduce it to 60. And this machine could make all these decisions independently. You didn't need crew members to do that anymore.
Wow.
And the Star Trek is about it's about science fiction, but it's also about human interactions a lot when you look at it, because the whole contrast between Spock and Kirk, or Spock and McCoy, is the difference between emotions and lack of emotions, right? Or just
right.
Well, so the key thing that this particular system was taken over the Enterprise, and the Enterprise viewed its ships, Federation starships, as real enemies, and it started shooting them for real. And then they realized that obviously they had to do something. And what happened was that Daystrom talks to the computer, and he tells them what it was doing was wrong. So he had programmed this computer with his own engrams, his own sense of right and wrong, and it heard him, and it stopped the attack.
Oh, cool.
So that you should watch that.
I'm gonna check that out. I've seen every episode. I don't know how I don't remember that one. That show was pretty intense for the time. I'm.
Oh yeah. So yeah. William Daystrom is played by the actor William. Daystrom is played by William Marshall, the Shakespearean actor.
Oh, cool.
Very imposing, sort of voice and what have you. So
yeah,
it's cool.
That's cool.
The coolest thing.
Yeah. I was just talking. The last guest I had on we were talking about artificial intelligence and some war games, real life war games between China and America. It's very scary with, like, implementing AI. And he was talking about how the United States, at least, and our allies, were keeping a human in the system, in the AI system or these military systems, just for that very reason. So that's cool.
So this is you'll like this episode. The Ultimate Computer, it's called.
I'm gonna check that out today.
Yeah, cool.
All right, cool. Thank you so much, Emery.
Oh, David, thank you so much. My pleasure.
I really appreciate all your time.
All right, thank you. Stay safe, man.
All right, bye.
I'll see you then. Bye now.